Well, great. Thanks, everybody. Welcome back to Care Decoded, the show where we simplify the complex world of documentation, coding, and clinical AI to power better care. And today's theme is risk adjustment in 2026, precision, policy, and the future of compliance. I'm your host, Michael Lesnik. I am the Vice President of Provider Sales here at InfoScience, and today I am joined by Dr. Shannon Decker. She is a leader in healthcare innovation and policy. She's been at the forefront of helping organizations prepare for the next wave of regulatory change. And as a personal aside, if you've ever been to a RISE conference or any sort of risk adjustment conference, I'm sure you know Dr. Decker. She's been in this game a long time and she's an absolute expert. So we're really excited to have her on today. So thank you, Dr. Decker, for joining us. And today we're here to talk about what 2026 has in store for risk adjustment. And why accuracy and compliance have never been more critical. From CMS's RADV audit strategies to how AI is reshaping the landscape. And now with the recent court ruling vacating the RADV final rule could mean for the future of audits and compliance. So that's obviously a topic that's sort of fraught with uncertainty. So we'll get into that. And ultimately, we'll just try to decode what leaders need to know now to prepare for what's ahead. So in terms of getting into some of the questions for you, Dr. Decker, I think where we'd like to start is just setting the stage, for what the 2026 landscape is going to look like from a risk adjustment standpoint. And I think the big item is the RADV audit rule, right? And the CMS's final rule on extrapolation was really expected to raise the stakes dramatically. But just weeks ago, a federal judge vacated that rule, right? Basically halting the government's plan to claw back billions of dollars. So the opening question to you is, how does that ruling kind of reshape the compliance landscape for health plans and providers? And does it give the industry breathing room, or is this just temporary uncertainty until CMS appeals or revises its approach?
What a great question, and thanks for having me today. I really think that I wrote an article about this when it came out, and really see it as just being a stay, but definitely, not something that we're out of the woods on, or that we can take our eye off on. And so while it might be a brief pause, I do expect CMS to come back with either a similar rule or something else, because there has been a lot of talk in the industry about the need for compliance and this understanding that there may be some folks that are taking advantage and submitting things that wouldn't necessarily be appropriate. And so this is an opportunity to right those ways, if you will. And so while I think that it's a brief pause, it gives everyone a little more time to get their records in order and make sure, that they have everything together. I think going forward, having compliance in place is going to be super important, more so than ever. And so it's definitely something that you're going to want to still make sure that you're keeping an eye on and focusing on.
Gotcha. Okay, so that's great to know. So it sounds like by no means does this sort of overruling stop the trajectory CMS was on in terms of increasing the compliance crackdown and trying to ratchet up the accuracy requirements. It's really just kind of for the time being, right? We've got a little more time to, as an industry, to sort of get our act together, because it's still going to happen sooner or later.
100%. It may not be exactly in that manner, but I definitely think that even if it wasn't, right, extrapolation was an opportunity to apply an understanding across the population that if you, say, weren't coding diabetes or accurately documenting diabetes, that more than likely you weren't doing well in other parts of your population. And so that was the logic really behind extrapolation. It allowed CMS to apply these broad sweeping regulation, if you will, across the population that you have. I do think that what extrapolation was intended to do, that we're going to see AI pick up on that. And so the audits that were promised, getting up to date on audits and then doing wider audits, that we can fully expect that.
Excellent. And that's actually a great segue into my next question, which is related to, the kind of revolution that's going on in terms of technology and solutions. And you just said it, right? But CMS is now going to be leaning more on technology, right? Including AI to expedite audits and expand oversight. So how does that shift change the regulatory environment, and what should health plans and provider groups be bracing for as a result of those technologies becoming kind of standard in the CMS workflow?
Well, it does have me a little concerned. Not that I'm a naysayer to technology. I love technology. I use a lot of technology, or think I do. But I worry about when folks put all their, I can't think of words today. I'm sorry. When they put everything in behind technology and believe all that it can do, because we know, right, there are still, the system is still fraught with some challenges. We know using AI over medical records that typically the accuracy rate has been 60 to 70%. It's getting better, but they still have to do, they still have to do overreading with a coder. What I worry about is us having this reliance on tools, and then not performing in a way that we need them to or expect. And so I think we have to understand that there's going to be a learning curve, not just for us, but for the technology that we're enlisting as well. And I would say for medical groups and for health plans that you still need to have your data in order. I spent a lot of time over the years working with data and find that it's wrought with challenges, and it's just like in building your house. If you don't have a good foundation, it's probably not going to stand up very well. And so the same thing, you can bring the best technological solution to bear, but if you don't have good data, right, it's going to be trained in the instance of AI, it's going to be trained on bad data. And so then, that's not going to yield you the results that you want. I think also, too, that, again, we put a reliance in technology and we think, and we don't question it. And I think it's important for us to continue, our job maybe shifts where technology takes over on some of the manual work and the things like that we used to do. What it allows us to do or calls on us to do is to be critical, right? And to be analytical and to look at that data and understand, is it really making sense, the story that it's giving back to me? And so I think it's going to behoove health plans and medical groups to make sure that their data is in order, and then to review it and to say, with what technology is giving back, does it make sense? And I'll give you an example. This was before the days of AI and NLP and large language models. But I was part of a medical group, and we were at risk, and we had a multi-payer contract. And one of our health plans came to us and said, we're looking for this particular diagnosis, and you need to answer this audit. And oh, by the way, we're going to take $1 million back from each of your IPA. And so it would have been upwards of $20 million that they were looking to recoup. We luckily had all our data stored. It was in a centralized repository, and we could go back to the record and say to them, I understand that you got these codes on these patients and that you're assuming that we're the reason, for these codes not being supported, but we were able to show support on each one, and the code actually came in from another system. So it wasn't something that should have been recouped from us. And so we were able to defend ourselves. But had we just taken, right, the word of, that report and not had our house in order, if you will, and had charts and things like that at the ready to defend ourselves and to be able to demonstrate in every instance, here's the code, it's well documented and well supported. Had we not had that, we would have had to have paid those monies. We wouldn't have had a leg to stand on. And so I think that even though we think technology has made our lives easier, it maybe has in some ways, but there are in other ways that we need to step up. And we need to make sure that we're applying the appropriate diligence to ensure that technology is working in our best interest.
Yeah, and that's an amazing story, and I'm really happy you shared that
Yeah.
because particularly when extrapolation was going to be the future,
Yeah.
there was a lot of concern. I deal primarily with provider groups, right? And I think there was a lot of concern about generally in the industry, a lot of people think, well, risk adjustment compliance is more of a health plan problem, right? The plans are the ones who are on the hook. If CMS is, issuing fines and clawing back penalties, so provider groups tend to think they're like a step removed from that risk. But you just said that's absolutely not the case, right? Your medical group was being demanded by the health plan to compensate and repay due to a compliance issue. And that was, I think, going to be a really big concern with extrapolation. It's still going to be a really big concern just going forward. But um, I love when we hear anecdotes like that, how it's, we're all sort of in the same boat when it comes to compliance and coding compliance, right? Health plans and providers, no one's, this is not one group's problem, right? Everyone's on the hook for non-compliant coding.
And you asked me if I could just add on, you asked me about the landscape for 2026. One of the things, 'cause we work with provider groups as well, and one of the things that we're noticing, especially since the introduction of V28, is that health plans are looking to partner with physician groups that are willing to take risk and to be, delegated that risk. And we're seeing more and more of that, and it's spreading throughout the country. And I've spent a lot of my career in California, though I've worked across the country. But I can tell you, most of California, right, is a delegated risk model. The physician groups have been taking risk for many years now, over 10. And, they're capitated. We're seeing more of those contracts roll out in other states. And so I think because of V28, and a lot of the changes to quality, the emphasis on controlling your MLR and total cost of care, that we're seeing more and more of those contracts being written. So while folks may think they're removed or I'm just in fee for service, this isn't going to touch me, not so. I've actually, worked with groups in fee for service too on documentation. And so it really, to your point, touches all of us and is going to be important that we shore those things up.
Absolutely, yeah, and right. It was like California and Florida and maybe some of the states in the
Yeah.
Southwest were really kind of the epicenter for these. But you're right, and even more, even beyond just the geographic spread, I've actually been talking with a number of specialists like cardiology
Yeah.
groups and orthopedic groups, vascular groups who are getting into risk-based contracts with their payers. So it's not just primary care anymore, and it's not just certain pockets of the country. It's really coming for all coding eventually. So really interesting stuff there. Thanks for sharing. Um,
Sure.
Moving into the next question. So by 2026, this is an interesting one. CMS had intended to clear all the audits for the years of 2018 to 2024 and move into auditing every plan annually. Here we are now, right? 2 months left in 2025. In light of the court's decision, do you think that timeline still stands? And what does the acceleration or potential recalibration of audits tell us about, where CMS is going with that timeline and their priorities?
I've had folks ask me too, when are they going to hire all the coders that said they were going to hire? And I think that the timeline may slip a little, but not by much. And again, just the way, AI and technology is growing in leaps and bounds. I think we're on the 5th version of ChatGPT, and it just gets better and better, and we move from, and forgive me, I know I'm not overly technical, but I understand, we've moved from the early days of AI to now agentic models that can process, it's no longer processing just a line, a sentence, or a few words together, but they can actually take in pages and pages of data and make sense of it. And so these models are getting smarter and smarter. I think that's what we can expect. I think technology is going to allow them to catch up in no time flat. And, we were talking about extrapolation. I think what we can expect to see too is audits at 100% of our records. I definitely think, that that's something that could be a part of our future. Just knowing the way technology is going and all the developments that we're seeing in our industry.
Wow. Wow, that's really interesting. I'd not thought of that, but you're right. I mean, this idea of extrapolation may not be needed if they can actually get to
Yeah.
every chart using AI. So the risk is there no matter what, which is that's a really interesting concept. Okay, thanks for that. So I think we've spent quite a bit of time sort of talking about like the landscape heading into 2026 and some of the regulatory stuff. I want to get into some of the implications for the specific implications for health plans and providers now. My first
Sure.
question under that category is for health plans, like what are the biggest risks if their risk adjustment programs aren't meeting the highest standards of accuracy, especially now that we've got this sort of layer of regulatory uncertainty on top of the existing compliance expectations? Like what does that mean for health plans?
I think, and just coming from a risk conference, the conversation a lot was around getting your house in order and that you can't rely just on risk adjustment anymore. And I agree with that. And that's been the sentiment now for a few years, is that you also need to be thinking about quality and meeting your quality gaps. And more, I would say within the last couple of years and the advent of value-based care, there's been an emphasis on total cost of care. So I do see more of an emphasis on those components of the business, but that doesn't mean that risk adjustment shouldn't be attended to, just because it was one of the first things I think that we were doing. I think that there are still opportunities within risk adjustment to do the things that we've always known to do better. There's an opportunity to make sure the EMRs are set up appropriately so that they're transmitting the data appropriately. I still talk to providers, if you can believe it, after all these years, that only think that you can put 4 diagnosis codes on a claim. And unfortunately, there are EMRs out there that are allowing our systems to be set up where they're making that so, or the biller, right, only is sending 1 diagnosis because they want to make sure that the claim gets through. And so I think, for health plans, what they need to focus on is making sure that they understand who their patients are and what their needs are, anticipate and work with them on preventative care as it relates to quality, work with them too on total cost of care. So making sure that they are not going to the ER, right? That maybe they're going to the urgent care, or that their physician network is substantial to the extent that it can treat patients, right? That the patients within your geography that have those needs at different times. But then also too, I think it's working with your provider groups and helping them to scale that wall, right, of as far as being able to provide good data. But I still think that there are opportunities around the basics that we always knew, making sure that patients are going and seeing their physicians, making sure that, ideally it's proactive versus reactive, those visits, so that they can manage care. Documentation is still a need, making sure that you're documenting to the highest level of specificity, making sure that you're signing off on charts, making sure that if you're capitated especially, that they're submitting those claims. So a lot of the things that we knew were challenges before remain challenges today. And I think that there are opportunities for us to continue to improve on that. And I think it's more so important now because with V28, we know we've had a reduction, right, on some codes. There's been some added codes. There's been some collapsing of codes. But some of the things that I think that we can think about when you think about the V28 model is, there's additional risk for condition counts. We had that before, but the number, right, the RAF points that were associated with that went up. There's more RAF associated now with disease interaction. There is more RAF associated with some conditions. There's more RAF value attributed to the demographic value of patients. And so again, if you're seeing patients and you're capturing all their conditions, right, really giving a true picture of the acuity and the chronicity that those patients carry, that burden, that, those are the things that I think that we need to continue to focus on, because even though we've known it, it's been part of my work now for 20 some odd years, and it still keeps me pretty busy. Again, on working with physicians on documentation and data and so on and so forth. Long answer, apologies, but
No, that there's a lot.
lots of stuff in there.
Yeah, there's a lot of good stuff in there, and I'm happy to hear you talk about quality becoming more of a priority. Because, and just a little aside here at InfoScience, we obviously have an HCC coding solution that's sort of our flagship product, but we do also have a quality and care gap solution. And just earlier
So,
today, we were having an internal call about beefing that product up and making it more valuable, because we also think that's going to be, an area where customers can differentiate themselves from the folks they're competing with for these CMS and ACA dollars. So
I
thanks
hope
for sharing
so.
that. You talked a bit about, that question was primarily around health plans. You did touch on some of the provider points as well, but I want to go a little bit deeper, because for providers, right, who are in value-based care risk arrangements, how are these RADV and compliance changes going to affect the day-to-day documentation expectations, right? Given CMS's accelerating use of AI to scrutinize more claims more quickly, how must providers' documentation workflows evolve to generate better data, right? We talked about data at the top of the earlier in the conversation. Like, what do they have to do so they're meeting that new standard of precision, rather than just sort of doing the status quo and satisfying the current rules?
I think it's a great time to ask for help. And I know a lot of folks will say, well, I can't invest in tools or I can't hire more people. But I think that we have to understand the lanes in which we're good and stick to them. And I think that when I've worked with physicians on their documentation, what I always tell them is document to the highest level of specificity those conditions that enter into your mind as you're assessing the patient. It doesn't mean that you have to, scratch the surface for every rare thing that's out there. But if it entered into your mind when you thought about what prescription you needed to write for that patient and what tests that you needed to order when they came to see you today, then those are the things that I want you to document. But beyond documentation, you need to make sure that you have systems set up appropriately. So gone are the days of, it's not that you couldn't use a freeware version of an EMR or set something up yourself, but have someone take a look at it. Make sure that it's set up appropriately, that it is sending all the data and the appropriate data. I've seen, and I'll just give an aside, but I've seen an EMR set up with a generic specialty code, while CMS has very specific specialty codes that they accept. You have to make sure that your system is set up that way. Same thing with what I was mentioning about the diagnosis codes. An in-office claim, a professional claim, can accept up to 12 diagnoses, and there's an opportunity to even split a claim to allow up to 24. But yet there are a lot of systems that are still adhering to 1 or 4 diagnosis codes. So there's all sorts of expertise that's out there that I think that you should reach out to. Have someone do an assessment of your systems, maybe where your workflow can improve, what all the opportunities. I think, also too, leaning on particular technology. I know that a lot of doctors are using systems that record their notes for them when the patient is in front of them. Or maybe there's an opportunity to hire a really good, medical assistant or a nurse practitioner or some extender that can help you in your office with that type of workflow. But definitely, especially if you're looking at risk contracts and getting into those, I would make sure to do an honest assessment. And I always think about, what are the 3 levers that I can push on in order to prove or improve our activities around risk. And those are, how can I make sure that my patients are going to come into the office and access me in a way that's appropriate, that after hours, again, that they're calling my after hours line, or they know where the nearest urgent care is, so on and so forth. They're, accessing referrals. I have time for same day appointments and all of those components. Looking at technology, right? So what technology can I bring to bear? And again, is it my EMR? Are there instances for AI? And technology could be even adding that person right into your office and looking at new ways of, revising or handling your workflow that would be advantageous for the work that you're doing. And then the next lever I think that you can push on is providers. What can you do? Are there classes that you can attend? Is there a conference that you can go to that you can learn more about risk adjustment? What are things that are going to be looked on in audits? How you might consider data, the documentation that you're doing. One of the things with the RADV ruling that came out was that it used to be that you could provide 5 pieces of evidence to substantiate a code. We're no longer allowed that. You're allowed 2. But what I would say to providers is, if you have a patient who's a diabetic, they should be in to see you more than once a year, more than twice, right? There should be multiple instances of records that you can bring to bear to demonstrate that you've documented that patient's condition. And so anyway, those would be some things that I would look at if I were a provider group and concerned about compliance and RADV and how I might be successful in a risk adjustment arrangement.
Yeah. Okay. Really, really, really good stuff there. So big pictures, phone a friend, right? If you're in some of these contracts and
Yeah.
you're not really sure how you're doing, because it's crazy. I mean, I've encountered them too. There are medical groups who are still submitting 4 diagnoses like it's, the
Yes.
1980s, and we're still using paper forms. Like that's not the reality
Yes.
anymore, and that's a huge risk for value-based contracts and risk adjustment. So really good stuff there. So thank you for that. Moving into the next question, I'm curious what when you talk to folks in the industry, like what do you see as the kind of biggest blind spots or misconceptions about RADV among healthcare leaders today, if any?
I think the biggest blind spot, and I know I've mentioned it, is data. I think that there's an opportunity to improve on our data. I think that folks think that they're going to be able to find what they need when they need it. And, I have found that oftentimes it can be a struggle and not necessarily readily accessible. I think with RADV, I think that, again, that there are conditions out there that, when they're called for specific, on specific patients, the concern is, or they believe that we're going to be able to find the record, but there are challenges, right? And like you had said, there's paper records. You would be surprised, or you wouldn't, I guess, because you brought it up, but some of your audience may be. There are a lot of doctors that are still on paper. You have physicians retiring, are moving offices, records get lost. And so, having those records to be called up, to be able to support them. And then, like I said, I think that the blind spot is data and the cleanliness of data. I've seen a lot of systems. I heard of a medical group. I knew them a few years ago. They stood up a very expensive EMR system. It spent millions of dollars. They had that system in place, I want to say maybe 4 or 5 years, and now they've left it. And what a shame. But I think a lot of the things that it promised didn't come to light. And it wasn't because the capabilities weren't there in the technology. It was the data, again, that was being fed into the system, where there were opportunities to improve upon that. Even things like systems set up where the doctor is signing the note. If you don't close your note, your visit note, and sign that off and make sure that your credentials are included in that electronic signature, it could be rejected. It should be rejected. I'm not a coder, but I know that these are things that we come across when we're doing, chart review and pulling things for audits. And so it's little things like that, making sure that the date is on there, making sure that your signature appears and that they realize that it's a continuous note and not separate pages. So little things like that are going to be important, and making sure, again, that you have your records in order so that you can respond appropriately and quickly to those RADV audits.
Yeah, really, that's something I see every day in my work too. Is it's a bit of a it's what's the word? It's I can't think of the word, but it's cliche, right? Garbage in, garbage out, right?
Yeah,
And
absolutely. Yep.
technology it's a tool, and like any tool, if it's not utilized correctly, it's not going to do the job
Right.
you want it to do. And EMRs they're a tool, right? As much as everybody lives
Right.
in them every day, but you could have the best EMR in the world, and if you're not using it correctly, you're not going to do very well on a bunch of stuff like this. Um, so the next question I have, and it's, there might be some repetitive, I think you've already touched on some of this, but maybe we can go a little bit deeper. If you were advising a plan or provider group today, what are the top three focus areas they should prioritize in order to be compliant and competitive in 2026 and beyond?
I would say start by I would do an accurate assessment of my abilities, and I would look at the contracts that I hold and whether or not I can be successful on all those components. And I would look to renegotiate those contracts. I've come across a lot of groups that are working off of contracts from 2012. It's a different world. And there may be things on there, especially if you're a provider group, that you're taking risk for that you have little influence over. And so those are things that you're going to want to talk about with that health plan that you're contracted with, about what is the appropriate, right, DOFR and delegated task. The other thing that I would say to take a look at would be, again, looking at data, find a way to centralize data to the extent that, and I did this with a group, we brought all the records in-house, and we were a medical group, and we offered to the doctors free storage just so that we could hold their records, and then we would also respond to any other audits that they might get. And for that service, it allowed us to have that data at our fingertips when we needed it. And it was organized in a way that, again, I could get to quickly, because that's the thing with these audits as well, is that you're going to need to be able to respond very quickly. And so you want to have that data close to you. The other thing I would say is take a look at your networks. You need good relationships with your specialist. You need good relationships with your hospitals, so that, again, you can get that data. And then also, too, it's not enough to manage the patient at the primary care level if you're entering into risk contracts. So there's other components that are taken into consideration. And, CMS has an expectation, too, that you're fiscally healthy and operating, right, in financially smart ways. And so it's important to make sure that you have those connections with your specialist and with your hospitals, not just for the sake of getting records, while that's important, but also then to being able to manage patients appropriately as those contracts call for.
Yep. That the contract thing is a great call out.
Yeah.
I've seen similar things where, I'm talking to a group, a medical group or a health system about risk adjustment coding, and they have like 4 or 5 Medicare Advantage plans that they have
Yeah.
lives attributed to them for, and they think that risk adjustment's really not that important to them. They're like, well, we don't think there's much
Yeah.
revenue at stake here in these contracts. And
Oh my gosh.
the truth is they just don't really understand their contracts, right? And it's not like I don't want to call people out on that, but you need to know what your contracts, how they're built, because you might be leaving a tremendous amount of revenue on the table if you're not adhering to that contract and performing to the specs in that
Yeah.
contract.
I've come across a lot of contracts, and a lot of the ones, the way they're written today is that before there's even risk money shared, you need to perform on quality to the extent that it's a gate, it's all or nothing, which I think is really difficult. It's almost an unconscionable contract in my mind, because the health plans aren't necessarily getting to 4 stars either. And there's all sorts of opportunities and different things that go into it. And I actually, what I was saying, know what you're responsible for. I'm thinking about a group that I worked with on a CAHPS survey, and they were held responsible for a question. It had to do with the uh, oh my gosh, I forget it. As far as the formulary, forgive me. And that was not really something that they had influence over, but the question was included against them in this CAHPS survey. And so then because of it, because they didn't get the appropriate scoring on the CAHPS survey, didn't matter how well they did on mammograms and colonoscopies and things like that, more expensive measures, they didn't get that bonus money. And then on top of it, they didn't get the additional monies that would have been attributed to them for risk. And we actually successfully renegotiated that contract and fought because of how that was going to be handled. Because like I said, it was unconscionable. It was truly unfair to withhold those monies. But I agree with you. I think that would be something to, take a look and understand, what does a 0.1 mean to your organization across your population? I've gone in and I worked with one group. In 2 months' time, we did a retrospective project. We earned them $50 million. With another group, we raised them within a year $11 million. It's little tweaks and little things that you don't realize that you may be leaving. Every code, I always have the mantra, every code counts. If it's appropriate for the patient, you need to make sure that it's getting submitted, because we know, right? We know when we look at a diabetic patient, or even a patient with COPD take, we know what the typical trajectory is going to be. That's what the risk model is. It's based on what we expect the medical expense to be on those patients. And we know what it is because we've been tracking it for years. And so really, risk money is a projection, right, of what we expect those patients to cost the system. If you're not getting those monies, to me, it's not about revenue. You stand to lose money, right? Because we know those patients are going to cost that money regardless. What you really need to be doing is capturing who those patients are, capturing the chronicity, right, of their illnesses. But in addition to that, then trying to disrupt that typical trajectory, getting their A1C in check, right? Making sure that they're taking their statins, making sure, again, that, they are doing the things appropriate, making lifestyle changes, losing weight. If they're doing all of those things, they have an opportunity to change what we would expect, right? Change those expectations. That's where the savings come in. But if you're just running things as you are and then not capturing codes, you're going to be in the red. It doesn't matter if you've captured some codes. You really need to be at this stage in the game. We need to be capturing everything. And we're not doing that today. There's a lot of stuff, like I was saying, that's missed.
Yep. And it's all true, right? All absolutely important. And it does bring up a good question though, which is, we're asking all of this of providers, right? We're asking them to not only treat the patient, but also do all this sort of, it is administrative work, right? Some of this stuff they're doing, but they have to do it. And the question becomes burnout, right? As health plans look to use more AI-driven documentation support into clinician workflows, like what should leaders do to try to make sure we're not increasing the burden on physicians, right? Rather than instead of creating new friction, right, for these programs, like what can we do to help make this process easier for them?
I think there needs to be those conversations and people coming to the table that can actually make decisions and do something with that conversation. I've been involved in a lot of conversations where everyone comes with the best of intentions, but nobody's able to really do anything outside of that, that boardroom. They talk a good game, they all feel good for an instance, but nothing really changes. I think that it warrants having those good, robust conversations and, trying to help one another. What are some opportunities or supports that can be put into place? And again, it might be health plans subsidizing, right, an assessment of the technology or the workflow, or having someone that specializes in, organizational management and efficiency go in and help design a better workflow. May be an opportunity. For physicians, it may be hiring some staff. Have your front office staff or your medical assistant. They can do things where they can prep the chart for you. An extender can do some of the screenings ahead of time before they even get to the room with you. They can be helping you with your documentation. You have to oversee it. You're signing off on that note, so you need to review it and agree with everything that's in there. But there's ways in which I think that you can introduce tools and staff into that workflow that can assist you. And I think that there are opportunities to lean on the health plans to either get a bigger share of the monies that they're earning, right, for taking care of those patients and signing up for those patients, and find ways to subsidize and help support you in putting some of those systems in place. And even the health plans have programs too in their areas that sometimes that physicians can lean on. But I think more than ever, it's really important that we're having, again, good conversations, and that those conversations are actually leading to something when folks, when the meeting's over and they leave the room, that work is actually getting done and they're doing something to advance and make things better in the lives of physicians. I've spent a lot of time, I'll just add, a lot of time with physicians over the years, and I can remember one in particular out in the desert in California, that said to me, if you want to help me, come look at this, or I'll give you this. And, we started with that. We looked at 50 charts, and we found an opportunity of where documentation could be improved. And we found an opportunity where we could add in a template to do the PHQ-9, right, on that patients, or when their patients were coming into the office, because there were opportunities there. So little things like that. But the thing is I didn't just go in and point to them and say, here's where you fall down in the data. We actually sat down in their instance of Athena, and we set up that template and put it in there so that the physicians could use it. We came back and we did sessions with their staff about how best to document, certain conditions. And so we actually did things. And the comment that I got was that, we lived up to the promises that we made. And I think that because of the work that we have, and it's so difficult and it's complex and it requires all these people to get involved, that's the thing. We have to live up to the promises that we make, and our words need to mean something.
That's the best thing you can hope to achieve as a solution provider or a consultant in the industry, right? Is actually delivering on what you're promising. And that is, unfortunately, a bit too rare in our industry. So I can absolutely relate to that. And I've got actually another anecdote along these lines. A good friend of mine's a primary care provider, and I was talking to him probably 3 or 4 years ago, and he was really starting to feel the burnout. Just working 6 a.m. to 10 p.m. because he was doing all this, the pajama time thing was real for him. And he works at a big health system, and to their credit, they actually did make some changes for him. They did 2 things. One is brought in a scribe. At first it was manual. Now some of them have moved over to like an ambient note taker.
Nice.
And then the other thing they did was actually they reduced his patient panel size just a little bit to try to make everything more manageable. Now, their group was doing really well in value-based care. So I think this is another story of, if you succeed in value-based care, it opens up more opportunities to help your doctors be happier, right? Like you've got the funds and you've got the systems in place to help them do their job more efficiently. But you can only have the funds to do that if you're succeeding in the first place, right? And just so happens they were. So they had the budget to do those things, right? Which is it's not lucky because they earned it, but they were fortunate that they had done that.
That's the intent of those monies, right? Totally. Is to be able to invest them back into the system, and you'll continue to grow. But if you if you're limited, right, in your understanding or your vision, then your revenue is going to be limited too, and your growth is going to be limited. And so you have to keep reinvesting in those systems if you're going to continue to grow.
Yeah.
And I'll just support you too in what you were saying about burnout. We know more than ever that there is a shortage, right, of physicians in this country, and it's only going to get it's only going to be greater, especially with our primary care physicians. There happens to be, though, an overage of nurse practitioners, which is interesting. And we see some things at CMS, too, going on with decisions around licensure and, what nurse practitioners are permitted to do and supervision in particular states. And so I think that we can see some developments there happening in 2026 and beyond, too, because we know that with medicine and with all these great technological advancements, that people are living longer, but not necessarily healthier. And so we have far many more people to take care of, less physicians, potentially more nurses. So it'll be interesting. I definitely think that there's opportunities around workflow to improve.
Yeah, sounds like it. I didn't know that. That's a really interesting fact. Final question for you here, and then we'll look to wrap it up. So, how should leaders think about embedding technology like AI-driven documentation support? And what does success look like when that's done well?
I think the best way to implement any system is to really think about what do you want, what do you envision at the end, and then work your way backwards. I think a lot of times when we look to implement technology, we just see a great piece of equipment, right? And we want to bring it back and put it in and get it going. But a lot of times we don't take into consideration whether or not we have the supports, right, to get that technology to go, or the downstream effect that technology might have. And so I think it's really important to bring all stakeholders together and, again, really understand the impact that technology can have for your organization, and really following it again, downstream of what are all the impacts that this could potentially have, and are these things that I'm willing to accept. But again, start with what you want to see, and then I would work backwards as far as all the steps that you would need to take to get to that final vision, and whether or not your organization can truly support that.
Yeah, that's a great approach. Sort of visualize the future, right? And then make your way
Yeah.
there. That's an interesting way to think about it.
Well, and I'll give you a story. I can think of a time that I could have bought what I refer to as the Ferrari of document repositories. It was fantastic. It was going to take 18 months to stand up. It would have cost me over $1 million, but it was the best one in the market. I would have needed a developer to pull all the charts that I was looking for, but it was a beautiful thing. And I think in a future vision, right, it might have worked for me, but what I had envisioned was that I needed something simple. And I knew with the staff that I had coders that I needed to be able to pull charts and pull them quickly. I needed something simple. I didn't necessarily want to spend a lot of money. And so I was able to secure a system that I knew that for 3 years, where I wanted to be in 3 years, it could support me. I could look at 10 years and beyond, but I wasn't there yet. And so I knew what I wanted to look at, where I wanted to be at 3 years, found the system that those needs, and then worked my way back and understood that I had all the pieces in place that I needed to support that system. And so that's the other thing too, is I would say that look at where you want to be, but look at it maybe in phases too. You don't have to go from 0 to 60 and, 2 seconds, if you will. Sometimes it's small steps and really what works well with your organization, so that you know that folks are going to adopt that technology and use it in a way that you envision.
Interesting. All right. Well, I think we're just about out of time here. So, Dr. Decker, I want to thank you so much for helping us unpack the future of risk adjustment coding and compliance. And, I think the message is pretty clear. Accuracy, it's not just a coding issue anymore. It's a strategic priority for survival in value-based care. So if today's discussion gave you new insights, please follow the show and share it with a colleague. And until the next time, let's keep decoding care together. Thanks, everybody.